Calcium hemostasis. Plasma calcium exists in three forms: iodized, free, that is 45%, which is in the active form; bound to albumin, that is almost 40%, and bound to anion, that is almost 15% of total. So here, when there is an increase in pH, that is less hydrogen ion, albumin binds more calcium, that will lead to decrease in ionized calcium. Example: cramps, pains, paresthesia, or carpopedal spasm. These situations will lead to increase in PTH, that will cause decrease in pH, that is more hydrogen ion, hence leading to albumin binds less calcium and increase in ionized calcium, and a feedback to decrease PTH again. This is the circle, how it happens. And there is an increase in pH, how it causes decrease in the pH by binding and to ionized calcium. Ionized or free calcium is a primary regulator of PTH. Changes in pH alter PTH secretion, whereas changes in albumin concentration do not cause any changes to PTH. Calcitonin. Calcitonin source is parafollicular cells, that is C cells of thyroid. Its function is to decrease bone resorption of calcium and regulation. It regulates serum calcium by increasing, that will lead to increase in calcitonin secretion. Calcitonin opposes actions of PTH, not important in normal calcium, but hemostasis, calcium hemostasis. Calcitonin tones down serum calcium levels and keep it in bones. That's how you can remember it. So calcium tones down. Glucagon. Glucagon source is made by alpha cells of pancreas. Its function is to promote glycogenolysis, gluconeogenesis, lipolysis, ketogenesis. Elevates blood sugar levels to maintain homeostasis when bloodstream glucose level falls too low. Example, in fasting state. Regulation. It's regulated by secreting in response to hypoglycemia, inhibited by insulin, hyperglycemia, or somatostatin. Insulin synthesis. Pre-proinsulin synthesized in rough endoplasmic reticulum (RER) of pancreatic beta cells. This will cause cleavage of pre-signal that will lead to pro-insulin. So from pre to it becomes pro-insulin. Stored in secretory granules, cleavage of pro-insulin, then exocytosis of insulin and C-peptide equally. Insulin and C-peptides are increased in insulinoma and sulfonylurea use, whereas exogenous insulin lacks C-peptide. So exogenous means the external insulin injections that we take. It does not have C-peptide. Its function: it binds to insulin receptors. Tyrosine kinase activity. Here you can see insulin bind to tyrosine phosphorylation kinase activity, inducing glucose uptake, carrier-mediated transporter. Here causes like increase in uptake of glucose into insulin-dependent tissue and gene transcription. Anabolic effect of insulin is to increase glucose transport in skeletal muscle and adipose tissue, increase glycogen synthesis and storage, increase triglyceride synthesis, increase sodium retention in kidneys, increase protein synthesis in muscles, and increase cellular uptake of potassium and amino acids, decrease in glucagon release, and decrease in lipolysis in adipose tissue. Unlike glucose, insulin does not cross placenta. Insulin-dependent glucose transporters, GLUT4, GLUT4, seen in adipose tissue, striated muscles, exercise can also increase GLUT4 expression. So that's why diabetic patients are asked to do exercise or walk so that they can have better GLUT4 expression that can uptake the insulin in the body. Insulin independent transporters that are GLUT1, RBC, brain, cornea, placenta. GLUT2 is bidirectional. Bi is to beta islet cells, liver, kidney, GI tract. Think two-way street. GLUT3, brain, placenta. GLUT5, fructose, F5, spermocytes, GI tract. SGLT1, SGLT2. These are like sodium glucose transporters seen in kidney and small intestine. Brain prefers glucose but may use ketone bodies during starvation. RBC utilize glucose as they lack mitochondria for aerobic metabolism. So to remember the insulin-independent glucose uptake, here's a mnemonic: brick lips. So B for brain, R for RBC, intestine, cornea, kidney, liver, islet, beta cells. Islets are beta cells, and placenta and spermocytes. Regulation. It regulates. Glucose is the major regulator of insulin release. Increase in insulin response with oral versus IV glucose due to incretin. Example like glucagon like peptide 1, GLP-1, or glucose dependent insulinotropic polypeptide GIP, which are released after meals and increase in beta cell sensitivity to glucose. Release decrease by alpha 2, increase by beta 2. Stimulation, that is 2 is equals to regulates insulin regulated by in 2 ins. Glucose enter beta cells. Over here you can see glucose by GLUT2 mediators which are seen in kidney and GI tract. That will cause increase in ATP generation from energy generation from glucose metabolism, closes potassium channel target of sulfonylurea, and depolarizes beta cell membrane. Voltage gated calcium channels open causing calcium influx and stimulation of insulin exocytosis. So here you can see diagrammatic representation of all the regulation we just talked about. So adrenal steroids and congenital adrenal hyperplasia. This is completely diagrammatic representation. You can go through it by yourself. I might just read and get confused over here. I do not want to confuse you. You can pause here and read step by step A, B, C. And here it's like it chart where it shows in which disease there is an increase and decrease of hormones and electrolytes and its presentation. Cortisol. Cortisol is from adrenal zona fasciculata of adrenal gland, bound to corticosteroid binding globulin. Its function is to cause increase in appetite, increase in blood pressure. It actually regulates alpha-1 receptors on arterioles that will cause increased sensitivity to norepinephrine and epinephrine, which is permissive action. At high concentration can bind to melanocorticoids, aldosterone receptors. Increase in insulin resistance by diabetogenic, increase gluconeogenesis, lipolysis, and proteolysis, that is, decrease glucose utilization. Decrease in fibroblast activity can cause poor wound healing, and decrease in collagen synthesis leading to increase in striae. Decrease inflammatory and immune response, inhibits production of leukotrienes and prostaglandin, inhibit WBC adhesion like neutrophilia, and blocks histamine release from mast cells, eosinopenia and lymphopenia, blocks interleukin-2 production, and decrease bone formation, causing decrease in osteoblastic activity. To remember the functions, you have a mnemonic, a big fib. Each one have their bone formation, blood pressure. Okay. Exogenous corticosteroids can cause reactivation of TB, and candidiasis block interleukin-2 production because it blocks interleukin-2 production. So all these functions seen here can be seen in one of the pathological disease called Cushing disease, known as Cushing disease. You will see striae, hunchback, central obesity, poor control, diabetic, and striae. So all these, and poor wound healing. All these can be seen in Cushing disease or Cushing syndrome. Its regulation is done by CRH. Hypothalamus stimulates ACTH release in the pituitary. So CRH stimulates ACTH. This will in the pituitary, and this will cause cortisol production in adrenal zona fasciculata. Excess cortisol causes decrease in CRH, ACTH, and cortisol secretion. So everything in this chain reaction, there is a feedback. Always there is a feedback in any hormone coming from hypothalamus to pituitary and then going to the organ. Everyone have a feedback effect on hypothalamus and pituitary. Chronic stress may induce prolonged cortisol secretion. Cortisol resistance, impaired immune competency, and dysregulation of HPA axis, the hypothalamus pituitary axis. The Cushing disease or syndrome that I have talked about is caused due to increased use of glucocorticoids or steroids, long-term use of steroids. Appetite regulation. So ghrelin is one of the hormone that is regulating the appetite. Let's see the function. So it stimulates hunger, orexigenic effect, and growth hormone release. Why a growth hormone secretagogue receptor produced by stomach. Sleep deprivation, fasting, or Prader-Willi syndrome can lead to increase in ghrelin production. So when you are not sleeping, that's why you're feeling hungry. So sleep so you do not feel hungry. Ghrelin makes you hungry and groovy. Acts as maybe this is mnemonic to remember. Acts on lateral area of hypothalamus hunger center to increase appetite. Leptin. Leptin is like satiety hormone, which is basically produced by adipose tissue. Mutation of leptin gene, central obesity. Obese people have increased leptin due to increase in adipose tissue, but also appears resistant to leptin anorexigenic effect. Sleep deprivation or starvation causes decrease in leptin production. Leptin keeps you thin. Acts on ventromedial area of hypothalamus, satiety center, or to decrease appetite. So basically, this will cause hunger, go eat, and this will cause no, stop eating. Endocannabinoids act at cannabinoid receptors in hypothalamus and nucleus accumbens, two key brain areas for the homeostatic and hedonic control of food intake that will lead to increase in appetite. Exogenous cannabinoids cause the munchies. Munchies. I don't know how to pronounce this. Sorry, guys. So, next page we have signaling pathway of endocrine hormones. So, CAMP is causes. Okay, there is a mnemonic, flat champs chalk. It's a weird mnemonic. So FSH, LH, ACTH, TSH, CRH, HCG, ADH, the V2 receptors, MSH, PTH, calcitonin, histamine, H2 receptors, glucagon, and GHRH. CGMP is BNP, AMP, EDRF, or non-nitrogen oxide, NO. Bad grandpa, think vasodilation and diuresis. IP3, okay, I do not want to go into this because all these are mnemonic to remember each of the signaling pathways taken by these hormones. I think you can read it by yourself. It's a self-explanatory memorizing thing, I guess. Okay, so from physiology now we have pathology. Endocrine pathology will start from syndrome. So syndrome of inappropriate antidiuretic hormone secretion, characterized by excessive free water retention, euvolemic hyponatremia with continued urinary sodium excretion, or urine osmolality that is more than serum osmolality. Body responds to water retention with decrease in aldosterone and increase in AMP and BNP. That will lead to increased urinary sodium secretion and hence normalization of the extracellular fluid volume. Hence it is a euvolemic hyponatremia. Here you see very low serum sodium levels can lead to cerebral edema and seizure. correct slowly to prevent osmotic demyelination syndrome, commonly called as central pontine myelinolysis. Uh, it's called SIADH, which SIDS causes include ectopic ADH, that is small cell lung cancer. These small cell lung cancer act as ADH secreting hormone secreting cancer. So that's why it's like ectopic ADH. CNS disorder, head trauma, pulmonary disease, drugs like SSRIs, carbamazepine, and cyclophosphamide. Treatment is fluid retention, which is the first line, salt tablets, IV hypertonic saline, diuretics, ADH antagonist, that is conivaptan or volvaptan or demeclocycline. Diabetes insipidus, characterized by intense thirst, and polyuria, with inability to concentrate urine due to lack of ADH central or failure of response to circulating ADH nephrogenic. So it could be central or nephrogenic. We have like divided central and nephrogenic, and each have their own features. The etiology, central, is from pituitary tumor or autoimmune trauma, surgery, ischemic encephalopathy, or idiopathic. But nephrogenic, DI, it could be hereditary, like ADH receptor mutation, secondary to hypercalcemia, hypokalemia, lithium, demeclocycline, the medication, or which is like ADH antagonist. Findings are, for central, we have decreased ADH, as there is no production of ADH centrally, no signaling. But in nephrogenic, we have normal or increased ADH levels. Here, this urine specific gravity is less than 1.006. Urine osmolarity is less than 300 millisosmolarity per kg. Serum osmolarity is more than 290 milliosmol per kg, and hyperosmotic volume, concentration, hyperosmotic volume, high osmotic volume. Water deprivation test, that is a kind of test where you see 50% increase, more than 15% increase in urine osmolarity only after administration of ADH analog. Whereas in nephrogenic, you will see minimal change in urine osmolarity even after administration of ADH analog, because as we said here, there is normal ADH or increased ADH levels. Treatment is desmopressin and hydration. Here you have HCTZ and indomethacin, amyloride, hydration. In both the cases, we need to hydrate. Normal saline. IV hypertonic saline. IV. IV because we need to immediately start hydration. And dietary salt restriction, avoidance of offending agent. So here there is a small note which says no water intake for 2 to 3 hours, followed by hourly measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. ADH analog desmopressin is administered if serum osmolarity is more than 295 to 300 milliosmol per kg, Plasma sodium is more than 145 MEq per liter, or urine osmolality does not rise despite a rise in plasma osmolality. Next is hypopituitarism. Hypo means decrease pituitary hormones. Here you have under secretion of pituitary hormones due to non-secreting pituitary adenoma, craniopharyngioma, or Sheehan syndrome. Sheehan syndrome is basically ischemic infarct of pituitary following postpartum bleeding, like in pregnancy-induced pituitary hormone, causing increased susceptibility to hypoperfusion, usually present with failure to lactate, absent menstruation, and cold intolerance. Empty sella syndrome, which means sella is the place where pituitary is sitting. So empty sella syndrome. Here you have atrophy or compression of pituitary, which lies in the sella turcica, often idiopathic, common in obese women, associated with idiopathic intracranial hypertension. Pituitary apoplexy, which is sudden hemorrhage of pituitary gland, often in the presence of an existing pituitary adenoma. Usually presents with sudden onset severe headache, visual impairment, example bitemporal hemianopia, diplopia due to cranial nerve 3 palsy, and features of hypopituitarism, brain injury, and radiation. Treatment is hormone replacement therapy like corticosteroids, thyroxine, sex steroids, human growth hormones. Acromegaly. Acromegaly means increase, huge in size. So acromegaly, excess growth hormone in adults, typically caused by pituitary adenoma. Findings are large tongue with deep furrow, deep voice, large hands and feet, coarsening of facial features with aging, frontal bossing, diaphoresis, excessive sweating, impaired glucose tolerance, insulin resistance, hypertension. Increased risk of colorectal polyps and cancer. Diagnoses are increased serum GF1, failure to suppress serum growth hormone following oral glucose tolerance test, pituitary mass seen on brain MRI. Treatment are pituitary adenoma resection. If not cured, treat with octreotide, which is somatostatin analog, and pegvisomant, which is growth hormone receptor antagonist or dopamine agonist. Example, carbogoline.